Welcome back, students. Now in this video, let's talk about Polycystic Ovarian Syndrome. See, this Polycystic Ovarian Syndrome, this is a misnomer because in the name there is Polycystic Ovarian Syndrome. They are not exactly the cysts, okay? In the name it is polycystic, but they are not the cyst. They are unruptured follicles or underdeveloped follicles. So Polycystic Ovarian Syndrome is a misnomer, and previously this Polycystic Ovarian Syndrome is called as Polycystic Ovarian Disease. They are one and the same, okay, and the names can be interchangeable. Now, first point is, this Polycystic Ovarian Syndrome is also known as 𝗠𝐤𝐜𝐿 syndrome, and this is a very much common syndrome in the females. How common is this syndrome? See, 1 out of 5 females in the world, are suffering with this disease, or I can say 20% of the females in the world are suffering with this Polycystic Ovarian Syndrome. Now, the question is, why Polycystic Ovarian Syndrome? Why this Polycystic Ovarian Syndrome is happening in the female? See, we will see what and all happening in the Polycystic Ovarian Syndrome, but why it is happening, we don't know the reason. Okay, please concentrate here. The etiology is unclear. We don't know. But it seems that the environmental factors and genetic factors and lifestyle modifications are very much important in the development of Polycystic Ovarian Syndrome. And important genes that are related with the development of Polycystic Ovarian Syndrome are DENNDA1 gene and THA-DA gene. Okay, so these genes are known to be associated with the development of Polycystic Ovarian Syndrome, and we don't know the exact reason why this Polycystic Ovarian Syndrome is happening. Now, having said that, let's continue. To say that a female is having this Polycystic Ovarian Syndrome, she should have a 2 out of 3 conditions. We'll discuss what are those 3 conditions, don't worry. Now, to say a female is suffering with Polycystic Ovarian Syndrome, we are having a criteria known as Rotterdam's criteria. So, important MCQ is Rotterdam's criteria is used. Okay, Rotterdam's criteria is used to put the diagnosis of Polycystic Ovarian Syndrome, and that too you need to have 2 out of 3. Now, so what kind of criteria it is? See, now the female should have oligomenorrhea or amenorrhea. That is, menstrual irregularities or menstrual abnormalities should be there for that female, like oligomenorrhea or amenorrhea. She should have symptoms of hyperandrogenism. See, what are the symptoms of hyperandrogenism, guys? If there is too much amount of androgens in the blood, hyperandrogenemia. Because of hyperandrogenemia, a female is having hyperandrogenism. What does that mean? She is having excessive hair growth, that too the male pattern. Okay, she is having excessive male pattern hair growth. What does I mean by male pattern hair growth? It's not simple excessive hair growth on the body. Excessive hair growth on the body can be called as hypertrichosis, but if I am saying in specific male pattern, that means a female is having hair especially on certain areas where a male likely to have, something like over the lips, this beard area, and the chin, and the chest area. So female is developing that thick hair or coarse hair on these particular areas. This is known as hirsutism, and this is because of hyperandrogenemia. Okay, and a female can have acne and even alopecia. All these are because of hyperandrogenemia. Now, enlarged ovaries or polycystic ovarian morphology. The third criteria to put the diagnosis of Polycystic Ovarian Syndrome is enlarged ovaries, a big sized ovaries, and that too they have a polycystic ovarian morphology. If you can see on my top here, see this kind of small cystic appearances, anechoic areas are seen, which are just looking like a string of pearls. So string of pearls sign is seen with Polycystic Ovarian Syndrome. Okay, important MCQ. Okay, now the question is, to say a female is having Polycystic Ovarian Syndrome, either she should have oligomenorrhea or amenorrhea along with hyperandrogenism, like the features of hirsutism, acne or alopecia, and enlarged ovaries. So out of these 3, at least she should have 2. Now the question is, a female is going to come to the clinic and she is having the features of hirsutism, and she is saying that she is having menstrual irregularities like oligomenorrhea or amenorrhea. But upon doing ultrasonography, there is no evidence of this polycystic ovarian morphology. Okay, there is no string of pearl appearance. Can I say that she is having polycystic ovarian syndrome? Absolutely yes. Why? Because out of these three, even though she is not having polycystic ovarian morphology, now she is not having this cyst. Okay, so usually the cyst should be more than 12 or more, and that too, that cyst size should be between 2 to 9 mm. Okay, even though she is not having this polycystic ovarian morphology, she is having menstrual irregularities and the features of hyperandrogenism. So because of this, I can say that she is having polycystic ovarian syndrome. Okay, the diagnosis is made. Now, the other points are, in these females who are having this polycystic ovarian syndrome, other than these three criteria or other than these three clinical features, she can also have obesity. Usually, obese females are more likely to get this polycystic ovarian syndrome. It doesn't mean thin females are not going to get. No, even thin females can get this polycystic ovarian syndrome. True. Insulin resistance is often seen in these females with the polycystic ovarian syndrome. What does I mean by insulin resistance? Like, insulin is not able to act, and that leads to increased insulin levels in the body of these females. So if insulin is unable to act properly, then that causes increased glucose levels. So there will be impaired glucose tolerance test. Okay, so what are the other features which are associated with a female who is having polycystic ovarian syndrome? Obesity and hyperinsulinemia or insulin resistance. But important point is, obesity or hyperinsulinemia or insulin resistance, they are not a part of diagnostic criteria. Diagnostic criteria only include these three: menstrual irregularities like oligomenorrhea, amenorrhea; hyperandrogenism, features like hirsutism, acne, alopecia; and ovarian morphology, polycystic ovarian morphology on ultrasonography. So these are the diagnostic criteria. See, in this slide, we have seen the diagnostic criteria Rotterdam's as well as the clinical features. So these are nothing but the clinical features in a female who is having PCOS. Now the question is, why PCOS? See, we have already said that the etiology is unclear. But every teacher have their own story in explaining the PCOS. Every teacher is going to have their own story. Okay, because no one don't know what exactly the story is. Okay, everyone will have their own story, and all those stories are true. Okay, now let's start our own story, and this story is going to clear everything. It's going to clear all the MCQs, and let's start our story. Guys, to start with, there are high levels of luteinizing hormone in this female. Okay, we are starting with the high levels of luteinizing hormone. Now the question, why high levels of luteinizing hormone? We don't know. Okay, later I will say why there are high levels of insulin hormone, not insulin, luteinizing hormone. But for now, take this point. There are high levels of luteinizing hormone in a female with PCOS. We don't know the reason. Now, if there are high levels of luteinizing hormone, means what happens? We know that the high levels of luteinizing hormone are going to act on the theca internal cells. So where exactly are these theca internal cells? We know around a growing follicle. Okay, around a growing follicle, there are these theca internal cells, theca external cells, and the granulosa cells. We know that the granulosa cells are going to make the estrogens. But what about the function of these theca cells? Especially these theca internal cells, they are going to make androgens for the female. Now the question is, if there are too much amount of LH, if there is too much amount of LH, that LH is going to act on these theca internal cells. Whenever the theca internal cells are bombarded with these high levels of LH, what happens? There is increased levels of androgens. Now the question, which type of androgens? Is it testosterone? Is it androstenedione? Or is it dihydroepiandrosterone? Or is it dihydroepiandrosterone sulfate? We will discuss it later. But for now, that these theca internal cells, they are going to make more and more androgens. Now what happens with these androgens? Now in this female who is already an obese female, where there is too much amount of adipose tissue in her, these androgens are getting converted into estrogens. That process is known as peripheral aromatization. The androgens are getting converted into estrogens, there is no doubt. And that process is peripheral aromatization. And where this is happening? This is mainly happening in the adipose tissue of the female, where the androgens are getting converted into estrogens. Now the question is, which type of estrogen? Mainly estrone. Okay, estrone. So it is E1, less potent form of estrogen. Okay, it's a E1. Normally, important point here, because of this peripheral conversion, there is high amounts of estrogen. Okay, well and good. And that too, which estrogen? E1. So normally, E1 to E2 ratio in a normal female, it will be something like 1:2. Okay, 1:2. But in this condition where there is too much amount of this peripheral aromatization and there is too much production of this estrone, the E1 to E2 ratio, simply gets reversed and it will become 2:1. Important MCQ. Okay. Okay, so well and good. So now just tell me, in a female with PCOS, there are high levels of LH. Is this true or not? Yes, absolutely true. In a female with PCOS, there are high levels of androgens. Yes, true. In a female with PCOS, there are high levels of estrone. True. Okay, well and good. Now let's continue. If there is too much amount of this estrogens, means what they are going to do? We know that estrogens will act on the endometrium and they cause endometrial hyperproliferation. Okay, well and good. But here the question is, if there is too much amount of these estrogens, they are going to down-regulate the pituitary, or they are going to down-regulate the release of follicle stimulating hormone. That is true. So we have already seen this in the menstrual cycle. If there are too much, if there are a certain level of estrogens, means estrogen will give negative feedback for the release of FSH. That's true. Okay, let me again teach you. If this is the pituitary gland, from the pituitary gland, from the gonadotropes, we are going to have this FSH, and this follicle stimulating hormone is going to act on the growing follicles, and these growing follicles, that the granulosa cells around them, they are going to make your estrogens. Okay, this is something normal. Follicle stimulating hormone, granulosa cells are going to make estrogen. But what these estrogens will do? Estrogens will give negative feedback for the follicle stimulating hormone. In the same way, in this condition, as there is too much amount of these estrogens, they will give negative feedback for FSH. So FSH levels will go down. Now if the FSH levels are going down, please tell me, what exactly is this follicle stimulating hormone? It stimulates the follicles. That's why its name is follicle stimulating hormone. When the follicle stimulating hormone levels goes down, the follicles are not going to develop properly. So that causes follicular atresia. If the follicles are not developed, then do you think ovulation will happen? No, there is no possibility of ovulation. So there will be anovulation in this female. Guys, this is the key point. We know that in a normal female, the ovulatory cycles are painful and regular. Okay, this is something normal. Ovulatory cycles are painful cycles, absolutely painful, and they are regular. Anovulatory cycles are painless cycles and they are irregular cycles. Irregular cycles means they are not coming to a proper time. So they are irregular, which means oligomenorrhea, or even they can stop amenorrhea. So why there is this oligomenorrhea or amenorrhea, that is the menstrual disturbances in a female with the PCOS? It's because anovulation is happening. Why anovulation? There is no FSH. Why there is no FSH? Too much amount of estrogens. Why too much amount of estrogens? Peripheral aromatization. So this is how we have to study. Okay, well and good. So anovulation, that causes irregular, menstrual bleeding or irregular menses, and that causes infertility. Guys, PCOS is the important, most common cause for the infertility in a female. Why? Why infertility? Why? Because there is no ovulation at all. If she haven't ovulated, how come the fertilization will happen? How come the pregnancy will happen? There is no possibility. So anovulation is the cause for the infertility in this female of PCOS. So PCOS is anovulation. Very much important. So what's happening in PCOS? Anovulation, that causes infertility. Okay, well and good. If there is this anovulation in this female of PCOS, there is no possibility for the development of corpus luteum. That's right. Normally during ovulation, what happens? The Graafian follicle, the matured Graafian follicle, it's going to rupture and it's going to release the ovum. We know it. But if there is no ovulation, there is no rupture of the Graafian follicle. If the Graafian follicle haven't ruptured means, how come the corpus luteum is going to form? So ruptured Graafian follicle is corpus luteum. If the Graafian follicles is not getting ruptured because of anovulation, there is no possibility of this corpus luteum to form. So corpus luteum is not formed, no corpus luteum. If there is no corpus luteum means, there is no possibility for the progesterone. Corpus luteum is gonna make your progesterones true. So no corpus luteum, no progesterones. So in a female with PCOS, there is decreased levels of progesterone in her body. So again, high levels of LH, high levels of estrogen, high levels of androgens, but decrease progesterones and decrease FSH. So they will ask you, what are the hormones which are going to be increased in a female with PCOS and what are the hormones which are going to decrease in a female with PCOS. So these are very important MCQs. Okay, now let's continue. Guys, I have said that the androgens are going to be increased in a female with PCOS. Just before I have said which androgens. Now the main important androgen which is going to be increased here is testosterone. Okay, so testosterone is the main hormone which is going to be increased. That is the androgen which is going to be increased. If I am asking about estrogens, which is the most common, like no, which is that estrogen which is going to be increased tremendously in a female with PCOS, it is estrone. Guys, here's something very much important to know. Please concentrate that testosterone is the main hormone that's going to be elevated. That too, it's not going to be elevated too much. It's not going to be elevated too much. It's just the mild elevation. Okay, it's elevated. Androgens are more, but not super high. They are elevated. That too, they are mildly elevated, and the levels are usually less than 200 nanograms per 100 ml or 200 nanograms per deciliter. Okay, it's not ml, it's a deciliter. Okay, this is something very much important. So testosterone mildly elevated, less than 200 nanograms per deciliter. Why I am saying in specific? Because see, there are conditions which just look like PCOS. For example, ovarian tumor. See, there are androgen secreting ovarian tumors means, and that ovarian tumor is producing androgens, and that androgens can cause hirsutism like features in a female, and that hirsutism like features may let you to think that this condition is PCOS. No. So you should exclude, okay, you should exclude the other possibilities which just mimic like PCOS. So testosterone levels are elevated but mildly elevated, less than 200 nanograms per deciliter. But in the conditions of ovarian tumors, which ovarian tumors? Androgen secreting ovarian tumors or adrenal tumors. Even in these conditions, the androgen levels will be high, but they are super high. Okay, they are super high. They are more than 200 nanograms per deciliter. Okay, so this is something very much important. Now, the other thing is, in a female with PCOS, androgen levels are increased. Okay, well and good. Which androgens? Main androgen is testosterone, but other androgens like androstenedione, DHEA, dihydroepiandrosterone, and DHEAS, dihydroepiandrosterone sulfate. See, these last two, they are the adrenal androgens. So sometimes they can also be elevated. So, but important is what we are going to measure. We are going to measure only the testosterone levels. Okay. See, in the diagnostic criteria, we are having this hyperandrogenism. So if I am talking about hyperandrogenism and hyperandrogenemia, I am talking about testosterone, not the dihydroepiandrosterone or dihydroepiandrosterone sulfate. I am not going to talk about the adrenal androgens. I am going to talk about only the testosterone. Okay. Having said that, let's continue with the next slide. Now, see, okay, I have to tell you this also. What is the reason for increased androgens? The reason for increased androgens are high levels of LH we have already seen, and that high levels of LH are going to act on the theca internal cells and they cause the increased androgens. Okay, well and good. But please concentrate here, guys. We know that a female with PCOS, she is having this obesity and she is having this insulin resistance. Yeah, well and good, true. If she is having insulin resistance, means it is true that her insulin levels are gonna raise up. Yes, insulin resistance. So body is making too much amount of insulin. Now if there is too much amount of insulin means, see, even this increased insulin can stimulate the theca internal cells. Now one more stimulation, the one stimulation is coming from LH and one more stimulation is coming from the insulin, and this increased insulin can also stimulate the theca internal cells, and that can further increase the androgen levels in this female. Okay, well and good. Now what else this insulin can do? Please concentrate guys. Here, increased insulin and the increased androgens in a female with PCOS, they can act on the liver. If they act on the liver, sex hormone binding globulins, okay, sex hormone binding globulin levels will go down. What does it mean by? So sex hormone binding globulins, if they are going down means there is no these plasmaproteins to bound with the sex hormones. So usually sex hormones, they are bound with the plasmaproteins. Okay, so androgens or estrogens, they are bound with the plasmaproteins. Because of the effect of insulin and because of the effect of androgens on the liver, sex hormone binding globulins, SGBGs, they are going down. So if the sex hormone binding globulins, if they are going down means we can have free androgen and free estrogen in the blood. So how this is going to affect a female with PCOS? If there are these free estrogens and free androgens means, see, they are free. If I am saying they are free, they are biologically active. Okay, they are going to be biologically active. What does I mean by biologically active? They can have their effects. So estrogens, what these estrogens are doing? Again, these estrogens are going to give negative feedback for the FSH. What these free androgens are going to do? They cause hirsutism like features. Okay, so this is what's happening in a female with a PCOS. So this is like, these are all the cycles. One thing will stimulate the other. Insulin stimulate the theca internal cells, and the same insulin can act on the liver and decreases the sex hormone binding globulins. So from this slide, what we are seeing is there is one more thing which is going to decrease in a female with PCOS, that is sex hormone binding globulins levels, they are getting decreased. Okay, so well and good. Now let's talk about what happens if there are these high levels of androgens. If there is increased androgens in a female means we have already seen that there are features of hirsutism. What does it mean by hirsutism? Growing of hair in a places where male usually have that hair, okay, or male pattern hair growth on the lips, like chin area, beard area, on the the chest area, in these areas where the male usually have this hair. Okay, well and good. And acne will be there and hoarseness of voice will be there. Okay guys, well and good. Now here I just want to say one thing. See, hirsutism, this condition, it is associated with PCOS. Okay, well and good. See, the most common cause of hirsutism is PCOS. There is no doubt. The most common cause of hirsutism is PCOS. Why? Because of high levels of androgen. Is there is too much amount of androgens in this condition? My question is there is too much amount of androgens in this condition? No, they are mildly elevated. Okay, the testosterone is mildly elevated. What if there is too much amount of androgens? If there is less amount of androgens, that will cause hirsutism. What if there is too much amount of androgens? Something like a condition with ovarian tumor or adrenal gland tumor. Too much amount of androgens. See, this too much amount of androgens will cause a more severe condition which is known as virilization. What is the difference between virilization and hirsutism? Hirsutism is a mild thing or less severe thing where there is just hair growth or where you can expect acne and hoarseness of voice. But with too much amount of androgens in the body, that can cause a permanent, irreversible and more disastrous changes which are called as virilization. What does I mean by virilization? There you will be having clitoromegaly. Okay, it's irreversible. Clitoromegaly will be seen in the female. There will be deepening of the voice. Okay, a female voice is now getting deepened and it's like a male voice. And there will be breast atrophy in a virilization. So virilization and this hirsutism, they are not one and the same. Hirsutism is a mild condition which is seen with the PCOS, and virilization, that's going to be seen with the ovarian tumors, androgen secreting ovarian tumors, serotoli-Leydig cell tumors or adrenal gland tumors. Okay, now let's continue with the increased androgens. Okay, increased androgens, it's going to cause the hirsutism, we know that. And in hirsutism, there is this male pattern hair growth. Yes, we know that. And the most common cause of hirsutism is PCOS. No doubt we have seen. Now, this is something important. If they ask you, most common cause of hirsutism is PCOS. Okay. Now, if they ask you something like this, most common cause of rapid onset hirsutism. Rapid onset means it's coming very fastly. See, with PCOS, whatever the hirsutism is there, it's gradually coming. Okay, gradual onset. But if you are having an adrenal tumor or ovarian tumor, there is lots of these androgens, and that lots of androgens will cause rapid onset hirsutism. So if they are mentioning this word MCQ, if they are mentioning this word of rapid onset hirsutism, you should think about androgen secreting ovarian or adrenal tumor is there, and you can know it by just seeing the levels of the testosterone in the body. If it is more than 200 nanograms per dl, it is suspicious about the ovarian tumor. Okay, well and good. Now, rule out congenital adrenal hyperplasia. What is this congenital adrenal hyperplasia and why we have to rule out? Guys, I have already said to you that PCOS is a disease of exclusion. What does I mean by? Or hirsutism, we have to exclude it. What does I mean by? See, there are many diseases which just simply looks like PCOS. For example, congenital adrenal hyperplasia or late onset congenital adrenal hyperplasia or non-classic congenital adrenal hyperplasia. See what's happening here with the congenital adrenal hyperplasia. Even in this congenital adrenal hyperplasia, the androgen levels will jump up, and these androgens will cause hirsutism-like features. Okay. So now what I have to do, I have to differentially diagnose that is this condition is CAH or is this condition in this female is PCOS. So for doing that, I'm gonna check the levels of 17-hydroxyprogesterone. Now you will ask me a question, why I have to check the 17-hydroxyprogesterone levels, sir? Because if it is congenital adrenal hyperplasia, late onset, that too late onset type or non-classical type, there you are going to have more amount of or elevated levels of 17-hydroxyprogesterone. Now you can ask me why there is high levels of this 17-hydroxyprogesterone. Now let's see why there is increased 17-hydroxyprogesterone levels in a patient with PCOS. Why? Because first let's see what normally happens in the body. This is what normally happens. See, from the hypothalamus, corticotropic releasing hormone is going to be released. That corticotropic releasing hormone is going to act on the anterior pituitary, and from the anterior pituitary, from the corticotropes, ACTH is going to be released, adrenocorticotropic hormone. This ACTH is going to act on the adrenal gland. Okay, very good. Now, when ACTH is acting on the adrenal gland, now please remember, now in the adrenal gland, cholesterol is getting converted into pregnenolone, and pregnenolone will be converted into 17-hydroxyprogesterone. This is our hormone, 17-hydroxyprogesterone. Now, 17-hydroxyprogesterone, it can enter into three pathways. Now, this 17-hydroxyprogesterone can convert into aldosterone. It will be converting into cortisol and androgen. See, mineralocorticoids are getting formed, glucocorticoids are getting formed, and androgens are getting formed from a single 17-hydroxyprogesterone. So I can say 17-hydroxyprogesterone, it's getting converted into aldosterone, cortisol, and androgens. There is no doubt. Also remember, we know that they are steroid hormones. Okay, glucocorticoids, mineralocorticoids, 6 corticoids, all of them are nothing but steroids. So that's the reason why they are getting from the cholesterol. Okay, they are forming from the cholesterol. Now, important point is, what's the main aim? What's the main aim of the ACTH? The main aim of the ACTH is to produce the cortisol. It's not about the aldosterone, it's not about the androgens. The main aim of the adrenocorticotropic hormone is to produce the cortisol. Okay, if there is enough amount of cortisol, what this cortisol is going to do? Cortisol will give a negative feedback again for the ACTH. So this is what normally happens in a female. Normally, okay, this is what's normally getting happen. ACTH converting cholesterol into 17-hydroxyprogesterone, and now this 17-hydroxyprogesterone, it will go into three different pathways: aldosterone production, cortisol production, and androgen production. Now what happens in a female with congenital adrenal hyperplasia? See, there is this congenital adrenal hyperplasia. what happens is there is a deficiency of 21 hydroxylase and 11 hydroxylase. If there is deficiency of 21 hydroxylase and 11 hydroxylase, there is no way aldosterone is going to form and cortisol is not getting formed. Aldosterone and cortisol pathways, see both these pathways need 21 hydroxylase and 11 hydroxylase. Because of the mutation of certain genes, there is deficiency of 21 hydroxylase. Important. Because of the deficiency of 21 hydroxylase, no aldosterone, no cortisol. So if there is no cortisol, please concentrate. If there is no cortisol, cortisol mediated negative feedback is lost. If cortisol mediated negative feedback is lost means what happens? There is increased ACTH release. There is increased ACTH release. Now increased ACTH will come and act on the adrenal gland. So there will be adrenal gland hyperplasia. Okay. So congenital adrenal hyperplasia. Why there is hyperplasia? Because of the loss of cortisol mediated negative feedback on the ACTH. ACTH levels increases. So there will be hyperplasia of adrenal gland. So what's happening in the adrenal gland? Now too much amount of cholesterol is getting converted into too much amount of pregnenolone, and this too much amount of pregnenolone is getting converted into too much amount of 17-hydroxyprogesterone. So that's the reason why you have lots and lots of progesterone. Okay, so lots and lots of 17-hydroxyprogesterone. Now tell me, there is so much amount of 17-hydroxyprogesterone. Now this 17-hydroxyprogesterone, can it be converted into mineralocorticoids like aldosterone? No, there is no way it can be converted into aldosterone. Why? Because there is no 21 hydroxylase. Can it be converted into cortisol? No, it cannot be converted into cortisol. Now whole this 17-hydroxyprogesterone, now it is getting converted into androgens. Now that's the reason why androgen levels are increased in a female with congenital adrenal hyperplasia, and this increased androgens are going to present with hirsutism and ambiguous genitalia. Okay, ambiguous genitalia, it can cause clitoromegaly and hirsutism. So that's the reason why we should check 17-hydroxyprogesterone levels to differentiate between whether the condition is a PCOS or whether the condition is congenital adrenal hyperplasia. If it is congenital adrenal hyperplasia, there is too much amount of 17-hydroxyprogesterone, and if the hirsutism is because of the PCOS, then 17-hydroxyprogesterone levels are normal. Okay, let's come back. So to rule out congenital adrenal hyperplasia in this female, what we have to measure? We have to measure 17-hydroxyprogesterone levels, MCQ. Now, so what is the scoring system for this hirsutism? The scoring system for this hirsutism is a Ferryman-Galway scoring, and a score greater than 8 is saying us that this female is developing the features of hirsutism. So what is the scoring system? The scoring system is Ferryman-Galway scoring, and the score greater than 8 is indicative of hirsutism. Okay, very good. Now this increased androgens, they can cause dyslipidemia. What does I mean by? See, these androgens, these testosterones, we know that the androgens are gonna decrease good cholesterol. They decrease HDL. HDL is good, and they increase LDL. So these too much amount of androgens are increasing the bad cholesterol in this female and decreasing the good cholesterol in this female. So that is the reason why I am saying a female with Polycystic Ovarian Syndrome will have the features of dyslipidemia, and this dyslipidemic features are because of the increased androgens. Okay, well and good. Now, let's continue with the increased estrogen changes. See, we have seen the changes because of increased androgens. What increased androgens are making? Now, let's talk about what happens if there is this too much amount of estrogens, that to estrol. We all know that estrogens are going to act on the endometrium. If estrogens are going to act on endometrium, means there will be endometrial proliferation. We know it. Estrogens cause endometrial proliferation. But in this condition, as there is too much amount of estrogens, that too much amount of estrogens will cause too much amount of endometrial proliferation, and that too much amount of endometrial proliferation will become endometrial hyperplasia. Now, this endometrial hyperplasia, it's a precancerous condition. We have already seen in the topic of endometrial cancer, there we have seen that endometrial hyperplasia, it's a pre-malignant condition. that anytime this endometrial hyperplasia, it may turn into endometrial cancer. So now our females who are with the hyperestrogen levels, they are at a risk of getting endometrial cancer. True. Now estrogens, hyperestrogenemia, it's not only a risk factor for endometrial cancer, but we know the breast tissue is acted upon by estrogens. If there is too much amount of estrogens, means these too much amount of estrogens can act on the breast of a female. So a female with hyperestrogenemia or PCOS is at a risk of developing breast cancer also. True. And she is at a risk of developing ovarian cancers also. So a female with PCOS is at a risk of getting which cancers? MCQ. Endometrial cancer, breast cancer and ovarian cancer. So very much important. Okay. Now let's see what other changes will happen in a female body who have this hyperestrogenemia. Okay. We all know that estrogens will give a positive feedback for the release of LH. And we also know that estrogens will give negative feedback for FSH. We know. See, what are the functions of estrogens? Estrogens will stimulate the endometrium. True. Estrogens will give positive feedback for the LH. And that's the reason why there is this LH surge. We know. In these conditions, as there is this too much amount of estrogens, that too much amount of estrogens are giving positive feedback for the LH. So, too much amount of estrogens, too much amount of LH. So, that's the reason why a female with this PCOS is having high levels of LH. See, we have started the pathophysiology of the PCOS with high levels of LH. There we have said, just think like we don't know what's the reason for high levels of LH. But now we are having a reason why a female with PCOS is having this high levels of LH. Why? Because in the condition of PCOS, there is hyperestrogenemia. There is too much amount of estrogens. We know estrogens will stimulate the release of LH. So that's the reason why hyperestrogenism or hyperestrogenemia causes increase LH in this female, and this estrogens will decrease the FSH. That's also true. We know it. So that's the reason why the LH FSH ratio normally LH FSH ratio is 1:2 normally, but in this condition of PCOS it have become reversed. Okay, it have become reversed like 2:1. So too much amount of LH, FSH decrease. So it is 2:1, and sometimes it can reach up to 3:1. Okay, sometimes it can be a 3:1 also. Okay, after seeing this, let's continue with the treatment. Treatment is going to be very easy if you understood what's happening with the PCOS female. Guys, the first thing we are going to suggest for a female with PCOS is to reduce her weight or weight loss. How weight loss is going to help in PCOS? If she is reducing her weight, she is actually cutting out the adipose tissue on her body. The adipose tissue is decreasing. If adipose tissue is decreasing means the place for aromatization, or I can say the peripheral aromatization is getting decreased, or conversion of androgens to estrogens is getting decreased. If there is no peripheral conversion, the estrogen levels will automatically decrease. So this is something good. We want to decrease the estrogen levels in this female of PCOS. Why? Because PCOS is a condition where there is too much amount of estrogen. So we are trying to decrease the estrogen levels in her. Okay, well and good. Now, what about her insulin resistance? We are going to treat her insulin resistance by giving a drug called as metformin. See, she is not a diabetic, but still we choose to give metformin to decrease her insulin resistance. Also remember that this metformin is having certain anti-hirsutic properties. If I am talking in pharma point of view, we all know that metformin causes megaloblastic anemia, and metformin is associated with lactic acidosis. Okay, so just to remind you that. Okay, so metformin is going to decrease the insulin resistance, and metformin is the drug of choice for treating insulin resistance in a female with PCOS. Also remember that it causes metabolic acidosis and megaloblastic anemia. That is a lactic acidosis, okay, not metabolic acidosis, lactic acidosis and megaloblastic anemia. Please remember that metformin is also helps in decreasing the weight loss. Okay, this is usually anti-diabetic drugs. They are associated with increase in weight, but this is a drug which helps to decrease the weight also. That's also going to be good in this condition. So what is the drug of choice for insulin resistance in a female with PCOS? It is metformin. After metformin, the kind of drug which we are going to give is progesterones. So how progesterones are going to help in treating PCOS? How means? Please concentrate guys. Estrogens, we all know that estrogens and progesterones, okay, so estrogens are mainly going to give a negative feedback for follicle stimulating hormone, and progesterones, they will give negative feedback for LH. See, PCOS is a condition where there is too much amount of LH. See, that's the place where we have started our whole pathophysiology. The whole pathophysiology of PCOS start with high LH levels stimulating the 𝗑𝐽 internal cells, producing the androgens. That's how we have started. So as there is too much amount of this luteinizing hormone, we can give negative feedback by giving the progesterones. So progesterones can be given and they will give negative feedback for the luteinizing hormone, and that's going to be helpful in this condition. After this progesterone, so what else problems are there in this female with the PCOS? Infertility. So how we can treat that infertility? First of all, why there is this infertility? Infertility is because of anovulation. So what we have to do? We can treat it by making her ovulate. We can treat the infertility by making her ovulate. So what we have to do is ovulation induction. So ovulation induction is done by clomiphene citrate and letrozole. But the drug of choice for ovulation induction is letrozole, and letrozole is the aromatase inhibitor. Let me tell you how this letrozole is going to make her ovulate, or how letrozole is causing ovulation induction. How means? See, letrozole we know it's a aromatase inhibitor. Now what exactly is this aromatase guys? Normally aromatase is the enzyme which helps in conversion of androgens into estrogens. Okay, androgens are getting converted into estrogens. That's what is known as peripheral aromatization. That's happening in the adipose tissue. We know it. But what letrozole is doing? Letrozole is inhibiting the aromatase. If aromatase is inhibited, this peripheral conversion is also not going to happen. So what happens to the estrogen levels? Estrogen levels will come down. Normally, please concentrate. What estrogens will do? Estrogens will give negative feedback to FSH. But when estrogen levels are coming down, estrogen mediated negative feedback on FSH is lost. So this FSH levels are going to increase in this female now. Okay, FSH levels now are going to raise. Now how this is going to helpful guys? See, it's a follicle stimulating hormone. Now if you increase the FSH levels in this female, this follicle stimulating hormone will come and stimulate the follicles. So the follicles will now grow, and these developed follicles, with the help of LH surge, what they can happen is the ovulation will happen later. So this is how letrozole is going to help in our condition. Important point to be noted here is, by using letrozole, how many follicles have developed? It's a single follicle have developed, and how many ova have released? One ova have released. So there will be a one pregnancy, not multiple pregnancy. Why I am saying this? There is one more drug which is known as a clomiphene citrate. See, clomiphene citrate will also work in the almost same mechanism. Don't worry, I am going to explain that mechanism. But using clomiphene citrate will cause multiple pregnancies. There is almost 6 to 10% chance that multiple pregnancies can happen with the usage of clomiphene citrate. That's the reason why we are not using it as a drug of choice. If someone asks you what is the drug of choice, then it is letrozole. Okay, it's an aromatase inhibitor. We are going to discuss how clomiphene citrate work and what are the side effects of clomiphene citrate in the upcoming slides. Okay, very good. Now after treating infertility, what are the other problems which are associated with this female. It is hirsutism. So how we are going to treat the hirsutism? The drug of choice for treating hirsutism is oral contraceptive pills. Please concentrate. Hirsutism is treated with oral contraceptive pills and they are the drug of choice. So how oral contraceptive pills are going to work here? Please concentrate, guys. If I am talking about combined oral contraceptive pills, okay, combined oral contraceptive pills, they are nothing but a composition of estrogen plus a progesterone, and they are mainly progesteronic in action, we know it, okay. So estrogen progesterone pills, combined OCPs, they are mainly progesteronic, which means I am giving the progesterones to this female who is having hirsutism. So how giving progesterones is going to help, guys? If I am giving progesterone means they will give negative feedback to luteinizing hormone. We know that luteinizing hormone stimulates the 𝐒𝐿 internal cells. Okay, we know it. Luteinizing hormone stimulates 𝐒𝐿 internal cells to produce the androgens. Okay. Now, if you are giving oral contraceptive pills, they are mainly progesterone in nature, and this progesterone is going to give negative feedback for LH. So LH levels are coming down. If LH levels are coming down means LH mediated 𝐒𝐿 cell stimulation is going to decrease. So 𝐒𝐿 cells will produce less androgens. If there are these less androgens means that's going to be helpful in treating the hirsutism. So this is how OCPs are going to help to treat the hirsutism in this patient. Apart from oral contraceptive pills, the other pills which you can use are anti-androgen pills. Okay, anti-androgen pills like spironolactone and cyproterone acetate. We know that spironolactone, which is an anti-androgen, which is also a potassium sparing diuretic. Okay, so spironolactone and cyproterone acetate, they are having anti-androgenic properties, so we can use to treat hirsutism. Why? Because hirsutism is because of androgens. So we have to use anti-androgen drugs like spironolactone and cyproterone acetate. Okay, well and good. Now after treating hirsutism, what else problems are there in this female of PCOS? Amenorrhea or oligomenorrhea. Menstrual irregularities are seen in this female. So how to regularize her cycles? Now if it is oligomenorrhea, like oligomenorrhea is nothing but too much lengthy cycles. She should have her menses by 28-30 days. Okay, by 28 to 30 days. What if she is having her cycles once in 2 months? Oligomenorrhea. Okay, so to treat that oligomenorrhea or amenorrhea, that menstrual irregularities, what is the drug of choice? Is oral contraceptive pills again. Okay, so for treating her oligomenorrhea or amenorrhea, we are going to use the combined oral contraceptive pills. So how these oral contraceptive pills are going to regularize her cycles? Now, how hormonal pills are going to help, guys? Hormonal pills are nothing but, okay, the oral contraceptive pills are nothing but estrogen plus a progesterone. Now, if I am giving the oral contraceptive pills to her, I am actually giving her a sheet of 28 tablets. Okay, in these 28 tablets, 21 pills or 21 tablets are hormonal pills. What does I mean by hormonal? These 21 pills, they contain this estrogen and progesterone. The remaining 7 pills are iron pills. Okay, the remaining 7 pills are iron pills. Now, from the first day of her menstrual cycle, till to 21st day of her menstrual cycle, she is taking this hormonal pills. Means she is going to take this 21 hormonal pills from her first day of menstrual cycle. So we are supplementing exogenously, we are supplementing estrogen plus progesterone for her 21 days of menstrual cycle. So from 22nd day, what we have done? Are we giving these hormonal pills? No, we are not giving the hormonal pills. We are taking out the hormonal pills. So what happened? There is progesterone withdrawal happened. So from 22nd day, we are not giving the hormonal pills. So there is withdrawal of progesterone. So what that causes? Withdrawal will cause endometrial shedding and expulsion of this endometrium. That's going to be menses, and that's going to be happen on the 28th day. So first 21 days I am supplementing the estrogen progesterone. From 22nd day I have stopped giving the progesterone. So what happened? So because of the decreasing levels of progesterone, there will be endometrial shedding and endometrial expulsion. So menstruation happens on the 28th day. So I'm totally taking charge of her biological cycles. Okay, I'm giving the hormones, I'm taking out the hormones. So her whole cycle, biological cycle, is getting controlled by me. So this is how I can regularize her cycles. See, if there are certain hormonal imbalances in her body, that's going to cause menstrual disturbances. Okay, we know that PCOS is a condition where there is too much amount of estrogen, less progesterone, no FSH, more LH. So because of that hormonal imbalances, she is having these menstrual irregularities. But what I am doing now here in this condition, I am going to balance her hormones. Okay, I am going to give the hormones, I am going to take out that hormones. So that causes regularization of the cycles, and this is how I can treat her menstrual irregularities. Okay, so by giving oral contraceptive pills. If she is having any contraindication for taking the estrogens, or if she don't want to take the oral contraceptive pills, then what we can use is progesterone only pills. Okay, POPs can be used. Okay, so POPs can be given for 10 days from her 14th day, means from 14th day of menstrual cycle, or from the day when she have ovulated, 14th day. From the 14th day, for the next 10 days, we can just simply give the progesterone and stop the progesterone. Means this is what's happening in a normal cycle. From the 14th day, there will be ovulation and there will be formation of corpus luteum and there will be progesterone. This is what happens normally. So we are doing similar thing. From her 14th day, we are giving progesterone for the next 10 days and we are stopping the progesterone. So stopping of progesterone will cause withdrawal of progesterone, and that can lead to menses. So we can do that, or at least we can give progesterone for 5 days. Means we have started it on 20th day of her menstrual cycle. For the next 5 days, we are giving the progesterones and we are stopping the progesterones. So progesterone is there. That will cause endometrial stabilization or endometrial decidualization, or will bring the secretory changes in the endometrium. So for 5 days we are doing that, and we have suddenly stopped the progesterone. That will cause withdrawal and there will be menses. So what I am trying to say is, either you can use oral contraceptive pills or you can use progesterone only pills for regularizing her cycles. Now there is one more surgery option which is available for treating this PCOS. So what is this surgery option and how this is going to be helpful? The surgery option is laparoscopic ovarian drilling. See what exactly we will do in this laparoscopic ovarian drilling. Let me tell you. Guys, we know that the 𝗓𝐞 internal cells in the ovary, they are going to produce the androgens, right? See, this is the ovary. In a condition of PCOS, there will be 𝗓𝐞 cell hypertrophy. Okay, there is a 𝗓𝐞 cell hypertrophy. Why there is this 𝗓𝐞 cell hypertrophy? Why? Because in PCOS, there is lots and lots of LH. We know luteinizing hormone is going to act on the 𝗓𝐞 cells, and too much amount of luteinizing hormone can cause the 𝗓𝐞 cells to undergo hypertrophy. So in a female with PCOS, there is this 𝗓𝐞 cell hypertrophy, and if there is so much amount of this thecal tissue, 𝗓𝐞 cells, there is going to be lots of androgens. Okay, there is going to be a lot of androgens. So what we can do is, we can burn out this thecal tissue, or we can burn out this stroma to decrease the production of androgens, and that's what we are going to do in the surgery. That is a laparoscopic ovarian drilling. What exactly we are doing in the laparoscopic ovarian drilling? We are burning the excessive stromal tissue, or we are burning the excessive thecal tissue. So doing that will decrease the androgens. Good. Doing that also increases the chances of ovulation. Okay, like it was seen that doing this laparoscopic ovarian drilling increases the ovulation chances again by 50%. She is anovulatory, right? Now she is in anovulation. PCOS is an anovulatory condition. By doing laparoscopic ovarian drilling, the chances of getting back to her ovulation again will increase by 50%. Okay, this is something very much important. Please concentrate here. Please see that in this condition, please see the surgery. Please concentrate, guys, what's happening in the video. See, this is the laparoscopic view of uterus. You can see these white color structures are the ovaries, and you can also see the pouch of Douglas. what we are going to do in the laparoscopic ovarian drilling? See, the surgeon is going to burn out the excessive stromal tissue. So burning out this stromal tissue will decrease the levels of androgens. So this will be done for both the ovaries. See, the ovaries are getting drilled and that excessive stromal tissue or the thecal tissue is getting burned out. So one ovary is completed. Now the drilling is continued with the other ovary. So this is how laparoscopic ovarian drilling is done. Now guys, we have seen how letrozole is going to work. Letrozole mechanism of action we have seen. Now let's see what is the mechanism of action of clomiphene citrate and how clomiphene citrate will cause ovulation induction. Guys, clomiphene citrate is a partial estrogen receptor blocker. What does I mean by partial estrogen receptor blocker? It blocks the estrogen receptors. Guys, please concentrate. Normally in the PCOS, there is excessive levels of estrogen, we know. What this estrogen is going to do? Estrogen is going to do negative feedback for the release of FSH, we know it. Now, if you block the estrogen receptors, estrogen cannot give negative feedback for the release of FSH. So what happens? FSH levels increases. Now this clomiphene citrate is a very powerful drug. It increases the FSH level so much so that this so much amount of follicle stimulating hormone, it will cause follicular development. The point to be noted here is one follicle is getting developed or many follicles are getting developed? Many follicles are getting developed, and these follicles, they will ovulate and there will be many ova, so that there is a chance of fertilization of all this ova, and that can lead to multiple pregnancy. So important point to be noted is a multiple pregnancy, it's a side effect. Okay, so it will be seen almost in 6 to 8% cases or 6 to 10% cases, there is a chance of this multiple pregnancy. So that's the reason why we are choosing letrozole instead of this clomiphene citrate. Okay, well and good. As it is causing the blockage of the estrogen receptors, it just seems like estrogen is not present in the body. Why? Because estrogen cannot show its effect. Why? Because the receptors are blocked. Now, in which females estrogen levels are going to be down? In a postmenopausal females, the estrogen levels are going to be very much low. So here, taking clomiphene citrate will also creating an environment which is similar to postmenopausal state. Why? Because there estrogen is not there. Here estrogen is there, but receptors are blocked. So taking clomiphene citrate will cause the postmenopausal symptoms like hot flushes. True, a very important thing. So clomiphene citrate causes hot flushes, multiple pregnancy 6 to 8% of the times, and ovarian hyperstimulation syndrome. See, we are going to discuss the ovarian hyperstimulation syndrome in a totally different video. But for now, just remember that there is a chance of ovarian hyperstimulation syndrome for 1% of the time. Now, it can cause ovarian cyst, ovarian cancer, visual abnormalities, MCQ. Clomiphene citrate can cause visual abnormalities, and GI and breast disorders or breast discomfort can be seen after the usage of clomiphene citrate for ovulation induction. So this is how clomiphene citrate works and the side effects. Now after seeing this, let's continue with the syndromes which are associated with the PCOS. What does I mean by? See, there is a syndrome called Hirsutism syndrome. Hirsutism syndrome. Hirsutism syndrome. What exactly is this Hirsutism syndrome? If a female is having this PCOS, then she is more likely to have hyperandrogenism in her body. Yes, that's true. Female with PCOS, she will be having hyperandrogenism. Insulin resistance, that's the reason why there is too much amount of insulin, and that insulin will further stimulate the theca cells to produce androgens. Okay, we have already seen this. And acanthosis nigricans. So Hirsutism syndrome means hyperandrogenism, insulin resistance, and acanthosis nigricans seen in a female with PCOS. Now the point is, what exactly is this acanthosis nigricans? Acanthosis nigricans is a dark velvety patchy discoloration in the areas of neck or the crural areas. Okay, so in the areas of crura, if you have this dark velvety patchy discoloration, that is known as acanthosis nigricans, and acanthosis nigricans is a marker for insulin resistance. See, if there is insulin resistance in the body, that causes this acanthosis nigricans. Important MCQ. Okay, well and good. So Heran syndrome is seen with the PCOS. Apart with the Heran syndrome, there is one more syndrome called as a metabolic syndrome, which is seen with the PCOS females. Or I can say, in a female with PCOS, she is more likely to have this metabolic syndrome. What exactly is this metabolic syndrome? Guys, please concentrate. Metabolic syndrome means, in a female, if you see increased triglyceride levels more than 150 milligrams per dl, or HDL, the good cholesterol, is going to decrease less than 50 milligrams per dl. See, why this is happening in a female with PCOS? It's very much obvious that in a female with PCOS, there is increased estrogens. In a female with PCOS, there is increased androgens, not estrogens, sorry, androgens. And we have seen that increased androgens will decrease the HDL, increase the LDL, and increase the triglycerides. So that's the reason why there is increased triglycerides in this female and decreased HDL. Now, because of the insulin resistance present in her, we are having this dysglycemias. Okay, the fasting blood glucose levels are somewhere between 110 to 126 mg per dl. Usually fasting blood glucose level should be less than 100. It should be somewhere around 90. But in these females, because of the insulin resistance, there is this dysglycemias. Okay, well and good. And she will be having more BP, that is more than 130 by 85, and her waist circumference will be more than 35 inches, which is saying that she is obese. So a female with PCOS is more likely to have all these conditions. So that's what is metabolic X syndrome. To put the diagnosis of metabolic X syndrome, she should have at least 3 out of these 5. Okay, out of these 5, at least she should have 3 out of them. So then we can say that she is having metabolic syndrome or metabolic X syndrome. Okay, so what we have seen, PCOS is associated with Heran syndrome and metabolic X syndrome. After seeing this, let's talk about the complications because of this PCOS. What kind of complication can have? Already we know it. See, there is a risk of endometrial cancer, breast cancer, and ovarian cancer. Yes, true. Too much amount of estrogens will cause mainly endometrial cancer. There is a risk of breast cancer and ovarian cancer also. Now, she is at a risk of getting coronary artery disease. Why coronary artery disease? Why? Because she is having too much amount of triglycerides, HDL is getting decreased, and LDL is getting increased because of increased androgens. So that can put her at a risk of developing coronary artery disease. And she is an obese female. Because of the too much amount of obesity and fat, she can have a sleep apnea. And it is seen that in a female with PCOS, she is likely to develop, or those in females with PCOS, studies have shown that they are at a risk of developing non-alcoholic steatohepatitis. So these are some important complications. Already we have seen that she is at a risk of developing metabolic syndrome. Okay. Apart from the metabolic syndrome, she is at a risk of getting endometrial cancer, breast cancer, ovarian cancer. She is at a risk of getting coronary artery disease, sleep apneas, and non-alcoholic steatohepatitis. So all these are the complications for PCOS. Okay, well and good. After these complications, let's see a very important topic. This is where you can 100% expect a question from a PCOS. Hormonal changes in PCOS. What hormones are increased and which hormones are going to be decreased? We know it already. See, let's concentrate on the hormones which are increased. Guys, androgens are increased, we know it. PCOS is a condition where there is too much amount of androgens, or hyperandrogenemia is there. That causes hyperandrogenism, hirsutism, we have seen that. Luteinizing hormone is elevated, yes, we know it. Estrone is elevated. This is something very important, not estradiol or E2. It is estrone which is very much increased because of peripheral aromatization, and that's the reason why there is too much amount of estrogens in this female. Now, insulin levels are increased. Why insulin levels are increased? We have seen that there is insulin resistance in this female, so insulin levels are increased. It is seen that in some females, not all the females, in some females, even prolactin levels are increased, but in some females the prolactin level stays normal. Okay, stays normal. So prolactin can be increased in some condition, can be normal in some conditions. Okay, we know that LDL cholesterol and triglyceride levels are increased. So the hormones which are increased we have seen, and LDL and triglycerides can also be increased in a female with PCOS. We know it already. And which hormones are decreased? See, because of too much amount of estrogen and estrogenic negative feedback, FSH levels are coming down. As there is no ovulation, PCOS is an ovulatory condition, there is no corpus luteum, so no progesterone, so progesterone levels are getting decreased. Because of the action of insulin and androgens on the liver, the sex hormone binding globulins level will go down. So SGBGs are getting decreased in a female with PCOS. True. HDL and apoprotein A1. See, because of the androgens, HDL cholesterol, good cholesterol is getting down. So this is very much important. So these are the hormonal changes which are seen in a female with a PCOS. I have covered all the important topics. Hope the lecture is helpful. Thank you.